Um, and so welcome to the Center for Behavioral Intervention Technologies monthly digital mental health webinar. And it's a real pleasure to have this month Skip Rizzo, who has been working in virtual reality and mental health for I guess decades really. So Skip is the director for medical virtual reality at the University of Southern California's Institute for Creative Technologies. And he's also a professor there in the School of Gerontology and in the Keck School of Medicine's Department of Psychiatry and Behavioral Sciences. So his, I think Skip is really, one of the, he's one of the founders in the field and continues to be really one of the leading innovators in developing VR for training, for assessment, for treatment and rehabilitation. He's been recognized by the American Psychological Association in 2010 with an award for outstanding contributions to the treatment of trauma. So Skip is going to be speaking for around 50 minutes or so. And if there's time, you're welcome to ask questions. You can ask them through the Q&A button there at the bottom of your screen. And if there's time, we will go ahead and answer them. So without further ado, Skip, it's a pleasure to have you with us.
Well, it's a pleasure to be here, Dave. And, I want to thank you again for this opportunity to speak to your group. I remember my last visit there a while back. Really impressed with what you were doing, and who knows what the future has in store. I think we still have another act to go in our collaboration, perhaps. Anyway, I'm going to present today on clinical virtual reality, what I term as a brief review of the future. And really quickly, what I'll do is a brief intro to what is clinical virtual reality, then touch on some of the core areas where there's an informed theoretical basis for the application of VR in a certain clinical area, as well as some scientific research to support the value of it. Show some examples in anxiety disorders, PTSD, pain management, physical cognitive assessment, rehab, if I have time, and then hopefully have some time at the end talk about virtual humans and the future. So let's start off. As David mentioned, I'm at the Institute for Creative Technologies at the University of Southern California, and our lab is the MedVR lab. It started in a primordial form in 1995, and we've chugged along, even though back in 95, the technology was not so mature. It wasn't, ready for prime time by any means. But the vision for the clinical application of VR was sound, and I hope I make that case sufficiently in this presentation. So over the years, as the technology got better, and the good news is that the technology has now in fact caught up with the vision. The vision for clinical applications of VR was always sound. It just, we had tech limits, and incrementally that tech has gotten better. But just over the years, I'm just going to show a few videos of some of the work we've done at various stages in our development. One that you'll see a bit more of is a PTSD exposure therapy application we call Brave Mind. This is what that looks like. We'll stop there because you'll see more of it later. This is what it looked like in 2008. So you can see the advances in computer graphics and so forth since that time. But in this case, we took an exposure therapy application and translated the functionality to be able to deliver tests of attention, memory, executive function, and so forth, as a way to perhaps provide better assessment in an immersive environment, in a context-relevant environment of TBI and service members that were in Iraq or Afghanistan. We don't just do military work. This is from 1996, 97 or so. Some mental rotation, visual spatial apps we developed on 3D projection systems. This is from 2003, a system that we developed for assessing children with attention deficit hyperactivity disorder or other attention impairments from other clinical conditions. Basically, the child has to pay attention to what's going on the board and respond to a stimulus sequence. Meanwhile, distractions, like the kid in the back just do a paper airplane, as you may have seen, school bus going by the window. And what you're seeing is what a child sees as they turn their head in the environment. So not only are we measuring the vigilance capabilities of the cognitive task, but the head movement to get some quantification of the hyperactivity or the distraction component. We'll see just a little bit more of this later and the latest version of this. So a lot of these apps I'm showing now are the initial prototype versions, and over the years they've evolved, and hopefully you'll see some of that. Some early work on motor rehab here, essentially using a Microsoft Kinect to capture the user's movement. If you're not familiar, it connects a 3D depth sensing camera, so this user is not wearing any wires, markers, or anything. And this is designed to be a way to make the very boring, repetitive, and frustrating activities of physical rehab more fun and engaging, so people do more of it, get the benefits of it after a stroke or a TBI or an orthopedic injury. Taking that same technology, very, very simple ask from the Cerebral Palsy Foundation, and that was make it so we could help kids with severe motor impairments play video games, whether you're a fan of video games or not. The idea was to give them the option to have activities like their peers. So this little girl had never played a video game in her life, and she had significant impairments in function, but she could in motor function. She couldn't raise her arm like that, as you see in the bottom panel there. And so that became the interface. Instead of a gamepad, which she couldn't operate, when she picked her arm up, the shark would jump out of the water, and so on. Some more recent work in this area I'll show later, so I'm not going to spend much time, but using head-mounted displays and sensors on the front of the headset to track hands for upper extremity rehab. In the virtual human front, this was an early application we developed for the USC School of Social Work for training novice clinicians in how to conduct a sensitive clinical interview in a veteran population.
Good afternoon, Sergeant Castilla. What brings you in today?
Well, my wife told me she thought I should talk to someone. She's been pretty concerned about me since a soldier suicided on base last week.
Did you happen to know the soldier?
Yes. He wasn't a friend, but I met the Marine once or twice. He seemed normal at the time. I guess I'm afraid I might end up like him.
Do you have any plans to hurt yourself?
No. It certainly crossed my mind, especially lately. I just need it all to stop. Sometimes I can't handle it.
So I like to say for that application, it gives novice clinicians a chance to screw up a bunch with a virtual patient before they get their hands on a live one, which is, I think, useful experiential training for clinicians in the early days of their career. Finally, last one I'll cover right now is SimCoach. This was from 2010, an online intelligent agent that we built for the Army. For all branches actually, but basically it was to provide a safe online place where people that were having difficulty, veterans, active duty, family members, could go online and talk to this character about PTSD, ask questions, get information about resources, but also the character could ask questions of the user that were thinly veiled screening questions of various clinical conditions like PTSD. And if the user reached some threshold, the character could say, hey, it looks like you're having some trouble. You want, punch in your zip code down at the bottom here, and I'll pop up a list of providers in your area, drawing from the National Center for PTSD database. And if you want, we can talk about what therapy involves for these types of conditions. So I'm not sure if I'm going to have time at the end to talk about him anymore. He's evolved a bit, but let me at least let him introduce himself here.
Well, I'm not a real person, if that's what you're asking. But I'm based on the personality and experiences of real soldiers and Marines. I'm still just a piece of software, but I'm getting better all the time, so hopefully I can be a helpful piece of software to talk to.
Okay, with that first shot across the bow, what is VR? If you're not familiar, from a technocentric perspective, combination of enabling technologies, computers, interface devices, body tracking, sensory displays, all put together to help people to become engaged in simulated computer-generated content. I prefer the more human-centric definition, which focuses on basic human-computer interaction, ways for people to interact in a more natural and intuitive way with computers to, go beyond the idea of, only using a mouse and a keyboard to hunt and peck, taking advantage of full use human functionality for interaction with computers and extremely complex content. Best metaphor in clinical VR is aviation simulation. So just as an aircraft simulator can serve to test and train piloting ability under a range of very controllable conditions, we can test, train, teach, and treat psychognitive and motor functioning, wide range of human functioning in VR simulations. And if you're a student of psychology, you get this in sort of the ultimate Skinner box. When we think about VR, think of the 3 I's: immersion, interactivity, and imagination. You don't always need all 3. It's good if you have at least 2. But when we talk about immersion, think about people wearing a VR headset like this service member in an Afghan village, as you see behind him. And as he turns his head, he's immersed in the environment, included from the outside world. We can also do this for other purposes. Like, again, this is a sensor affixed to the front of a VR headset, and you see what the user sees in a stereo pair on the left. We can track hand movement and allow that user to interact with 3D graphic content for upper extremity rehab. And again, we have a focus on building game-based apps to make it so people are more inclined to do more of the rehab they can benefit from, as you see here. Interactivity, it doesn't always have to be immersive. This obviously is in our lab, and this user is operating from using a Kinect and an early Kinect and a TV screen. And basically this application for balance training. So imagine an elderly person at risk for falls, wearing a safety harness, of course, shifting their weight side to side to drive the penguin down the slope, lean forward to speed up, lean back to slow down. A safe, fun, and engaging way to perhaps develop skills to prevent falls, which, as we know, in senior populations is a real problem for maintaining functionality. We also, the idea here is that it doesn't always even have to be on a big screen. If you build compelling content, you can deliver some of this stuff on a laptop, small screen, maybe even a mobile device to engage people. Another way that interactivity is key, it doesn't always have to be immersive. Now, what I'm going to show can be delivered in a VR headset, but for maximum usage, we built this system to be delivered on a regular computer monitor. And basically what it is a job interview training system. This was funded by the Dan Marino Foundation, the famous football player, with a focus on helping folks on the high end of the autism function spectrum practice their skills for job interviewing. These are folks who oftentimes are quite capable and can do a job, but their social skill difficulties make it hard for them to go into an interview or feel comfortable in an interview and present their best self. So this gives them the opportunity to practice with multiple characters, multiple job background contexts, and each character can be set at different personality levels. So this character, this backdrop, set at soft touch interviewer.
I'm glad you're here. In a minute, we'll get into some questions about the job. But before we do, why don't you just tell me about yourself?
Now, we can make her neutral or cranky, hostile, put her in a different backdrop for continuing in a series of interview questions, or we can pick a different character in a different backdrop like this.
This is an entry-level position. I guarantee there will be things you won't like about this job. That said, what's the most important thing you think you're looking for in a job?
So interaction with virtual environments doesn't always have to be immersive to have value. Now, since 1994, when the field really got its clinical traction, delivering exposure therapy for specific phobias, this is a short list of the clinical conditions where VR has been shown to add value, either as an assessment tool, treatment tool, or a tool for scientific research. And we'll touch on some of these as we move forward. There's a lot of reasons for this. I'm not going to go into each of these. This is a separate talk in and of itself, talking about VR assets. But if you're interested, send me an email. I'll pop you back this paper that goes into them horrific detail. This paper is a good cure for insomnia. If it's late at night, you can't go to sleep, this will do it for you. But I've distilled those apps into 5 core concepts that I think are relevant for how we apply VR clinically. And those are expose, distract, motivate, measure, and engage. We can expose people in a controlled way to things they fear, have been traumatized by, to help them confront and reprocess those experiences in a safe place. We can distract people from acutely painful medical procedures. We can motivate people to do things they might not do ordinarily. We can measure performance while people are engaging in a virtual world. And of course, we can engage people in content by the use of this novel technology. So we'll start off with exposure and talk about anxiety disorders, mainly specific phobias and PTSD. So as I said before, in the beginning, there was exposure therapy, and it made total sense because the theoretical basis for it is, basically a behavioral approach where helping a person to confront what they fear, but in a safe place where there's no negative consequence, will reduce the potency of those stimulus elements and make it so a person is more likely to engage in things that are minimizing their activities in everyday life, like flying or taking a job on a 2nd-story office building because they have fear of heights, or a wide range of areas. Public speaking is a big one. So it's theoretically informed. A lot of research in psychology over the years documenting the usefulness of this approach. And so back in 1997, if you had claustrophobia, you could go to Christine Batella's lab in Spain. She'd put you in this room, close the door on you, and then gradually move the wall in on you. And she had a variety of contexts. Elevators, of course, are big ones, and other contexts that were useful. Fear of heights was where the science really started to evolve in this area. A lot of research was done with that specific phobia. But taking a step back in time, in 1994, one of the critiques of even exploring this approach by some of the neo-Luddite naysayers of the time was that the graphics, would never fool anybody, that, nobody's going to take this seriously. It looks like a cartoon. But the good news was, first off, people with phobias are very attuned or they're very triggered by anything that has a whiff of what they're fearful of. And by immersing somebody in a VR environment where they feel like they're in a place, this was emotionally activating and it was effective. And that was one of the key things we learned very early on with VR, is that in spite of the impoverished nature of the graphic content, we could still fool the brain. So the frontal lobes know that this is a simulation, but the perceptual array of the experience taps right into the limbic system, fight, flight, or freeze response in the amygdala, and activates those emotions. And once you activate those emotions, you got something to work with in a clinical context. And fortunately, the technology's evolved and the graphics have improved. This is one simulation for fear of heights where you're standing on the edge of a skyscraper, not so realistic to everyday life, but they use it and it shows some effectiveness, and you'll see other apps in this area later. This one I love because it pits your fear of heights against your love of kitty cats. You'll see in the next slide somebody happened to walk out on that plank and rescue the cat, and you'll see them actually standing on a real plank to add a little textural or tactile content there. There he is. But you can see a wide variety of applications that, are quite a bit more realistic. They're not AAA game level graphics, but we don't have that kind of budget to build these kinds of things. But it's sufficient. We can do this stuff and get good clinical outcomes. Anyway, the good news is we can do this at a low cost. So $200, $300 headsets that have all the processing in the headset, no computer or tethered wire needed. This is really the future of clinical VR, like with one application here, which I might talk about later. I'm not such a fan of, even though it's a brilliant piece of technology, the Oculus Quest, but unfortunately they require you now to have a Facebook account, which makes it a problem because Oculus is owned by Facebook. Really makes it a problem for patient privacy and so forth. But here's what that looks like.
Oculus Quest is an all-in-one VR system. It's just you and your hands. completely free and immersed. With 6 degrees of freedom, state-of-the-art optics, and built-in audio, you can forget about wires, PCs, and phones. Oculus Quest is ready to play when you are.
So there are other companies producing these standalone headsets, and I think that's really the future, when a clinician can open up their desk drawer and pull out a VR headset, hand it to a patient, and be good to go. That's a barrier to adoption that has been reduced. Now, as far as the science goes, our group, another group in the same year, 2008, published meta-analyses on the existing literature at the time, documenting the value of VR in this particular area. That was followed up by another group in 2012, same results, same findings. 2015, another group followed up and actually documented the value of doing this work and its impact on actual real world change. You know, it's not just getting better in VR and self-rating yourself is better, but actually changing behavior in the real world after this kind of therapy. And most recently in 2019, the latest meta-analysis in a special issue of the Journal of Anxiety Disorders, pretty much makes a strong case that, VR delivering this type of exposure therapy is an effective and evidence-based approach for treating these kinds of anxiety disorders. Now, extending that to PTSD, even though PTSD is no longer considered an anxiety disorder in the DSM as its own category, we still use the same kind of approach. And when I talk about this, sometimes people say, wow, why would you do that? And again, as you'll see, we do this kind of exposure therapy because trauma-focused therapy in various forms, which has the best evidence. We got involved in this in 2003 with the idea of building a prototype. We built one in early 2004 and then finally got funded in 2005, particularly due to this article coming out documenting the urgency of the problem with veterans returning from Iraq and Afghanistan. And the problem has not gone away, as over the years, people have studied this. And even to this day, there's a lot of untreated PTSD in these service members. And as I mentioned, in 2008, the Institute of Medicine reviewed all the treatments for PTSD. And while most of them didn't have sufficient evidence to support them, the area of using exposure therapy within a CBT, cognitive behavioral therapy context, a trauma-focused approach, was considered to be effective based on the science. And so why we use VR? Well, the traditional method was always done in imagination for this type of therapy. Close your eyes and imagine you're confronting the experience you had, tell the story about what you went through, and so on. That's a pretty tall order for some folks with PTSD, where avoidance of places, cues, or memories is a common symptom with PTSD. So we felt that by using VR, we could systematically engage people in their trauma experience in a safe and progressive fashion. We're not the first people to do it. Prior to 2003, these are applications developed for virtual Vietnam, for driving, motor vehicle accident, PTSD, World Trade Center, and in Israel, a bus bombing scenario. This is what our system looks like, the 14 diverse worlds that we've created of Iraq and Afghanistan to represent the different places that people may have been in the experience of trauma. All of the actions in these environments are controlled by the clinician, as you'll see later, to pace the therapy.
By going through it there, it's not going through my head at night when I'm trying to sleep or when I'm with my wife, when times when I don't want it to come up and me start thinking about it. Traumatic things are not normal. You cannot handle the things that you've seen and done. And this is a tool that has helped me out tremendously.
Reliving the worst moments of his life has helped him to move on with his life.
I'm probably about 80% of who I was before I left, but I think that's pretty good after seeing and doing the things that we've done.
For Nightline, this is Dan Harris.
So one thing to keep in mind, no matter how cool this might look, it's not a replacement for good clinical skills. It's not a self-help treatment. You can't go online and download this and treat yourself. It's a tool to extend the skills of a well-trained clinician. Technology by itself does not fix anyone. It's really the clinical approach and the skill of the clinician in administering it that really has the effect. We can automate some of those processes and help people to do things between sessions, but I still have a old school view about a clinician being essential in treating any of the major psychological conditions. And the way we do that with BraveMind is to provide a Wizard of Oz clinician interface where the clinician can put the user in a relevant context of one of the 14 worlds and change the time of day, the lighting, the sound effects, the number of people in the world, the provocative elements, and so forth. And that's what it looks like, a clinician sitting in front of the control panel, operating and trying to mimic the trauma narrative that the patient is saying. Patients aren't just passive, just throw them in VR and it fixes them. They are narrating their experience as if it's happening right then and there. And the clinician is mimicking it to some degree. It's never an exact replica, but it apparently doesn't need to be an exact replica to activate emotion and to get a therapeutic response. We also use scent machines, physical props. We run the sound through subwoofers on a platform so that you feel the vibration of a motor or a concussive force of a bomb. All these things to try to enhance the experience and engage people more. Working with a new scent device, it's very portable and low cost with the OVR system. And we use physical props. You can hold on to a fake weapon. You can't shoot in the environment, but you have that prop in your arms with navigational controls on the prop. And with our partnership with the Norwegian military, we're experimenting with more actual embodied activity, walking on an omnidirectional treadmill. Some folks believe that's an important element for user engagement. So we're still, testing that out just to see how that works. So the research in this area, quick walk through one of the very early safety and feasibility trials with the first 20 treatment completers showing significant and clinically meaningful reductions post-treatment and a 3-month follow-up. At a finer point, 16 no longer met PTSD criteria at the end of treatment, 4 did not benefit, but that's just an open clinical trial. And that was from way back in 2008, I think it was published 2009 maybe. But more recently, with more intensive treatment, a 3-week program that Deborah Bidell runs at University of Central Florida, where patients fly in for 3 weeks, stay at a hotel every morning, do VR exposure every afternoon. They do a combination of traditional therapies that are customized to their needs called trauma management therapy. Really strong effect size here and low dropout rate in this approach. Barbara Rothbaum's group used our stuff, the early version of the simulation, not so much what you saw with the recent BraveMind, and saw not just clinical improvement, but maintenance of the gains at 1-year follow-up. And in addition to the clinician-administered PTSD structured interview assessment, they also did startle response with psychophysiological variables and showed that startle response, the hyperactive or hyperarousal component of VR of PTSD was reduced over time, and cortisol reactivity, a stress hormone in the blood, was also reduced when people were going through this. So positive gains. We've published about 6 studies so far on using this type of content for assessment of PTSD. Sometimes people don't self-report their symptoms, but their body tells us what's going on. As well, pre and post fMRI data showing change over time. Mike Roy's small study, 18 subjects showing changes in brain activation pre and post treatment. Trying to more objectively understand what's going on in the brain during treatment. A couple of randomized controlled trials. This was an early version of the system with only 4 worlds that showed equivalence to traditional prolonged exposure. We learned a lot from that and what we needed to build. And more recently, this is a randomized controlled trial that showed equivalence across all subjects, but when it came to people that had comorbid depression, VR was this was a pre-planned comparison, no p-hacking here. We predicted that people with depression would show better clinical response when in VR than the traditional format, and that in fact was found. Another study, offshoot of a previous RCT showed a reduction of suicidal ideation after treatment for both the imaginal exposure and VR exposure. So a lot of excitement, but still a long way to go. Science is never complete. One of the variations we did was to build out an application for military sexual trauma. We thought it would be easy. We build out some of these contexts within our combat worlds, but it turned out with interviews with patients that a lot of their sexual trauma was happening stateside, outside of military bases or military offices and so on. So we had to build out a lot of content like that. Here's an example of a perpetrator that is customizable, that may follow you around or turn up. Very provocative. We don't recreate the sexual trauma. We create contexts in which these things have happened in order to help the user or the patient to confront and reprocess these difficult emotional memories in a safe place with a good clinician. And the first study was a safety and feasibility trial. Everybody was concerned that maybe we might do more harm than good. So we were able to run 11 people in this trial to make sure we weren't hurting anybody. And in addition to not having any critical incidents, we also showed, even with a small sample, statistically significant and clinically meaningful reductions in PTSD. So aside from the efficacy data, one other element needs to be taken into consideration, and that is breaking down barriers to care, getting more people to seek treatment. And we believe that for some folks, maybe folks growing up digital or however you want to look at it, they may be more attracted to VR as a treatment approach and seek help that they could benefit from. And in our last randomized control trial, we did a simple thing at informed consent when they were told that they would be randomized to either imaginal exposure therapy or VR exposure therapy, and detailed on what that was as part of the informed consent to participate, but told that they wouldn't have a choice because it's science, they had to be randomized. But if they had a choice, what would they pick? Nearly 77% across all three sites, said they would have preferred doing it in VR. So good data on that front. Of course, still more work to be done, but I think we're on the right track, and we think we're at a sufficient level where.
We have a quick question from someone,
Sure.
But I realized the way that they did it is, if I could encourage you to write it in the chat or in the Q&A, and then we can ask the question. So I'll have you keep going till we know what the actual question is.
Okie
Thank
dokie.
you. Perfect.
So thinking about, everything we've learned and developed over the last 15 years or so treating combat related PTSD, well, plenty of trauma in the world, and it's not always from combat. So what we're really focusing on now is translating all of that towards treating first responders, for example, like police officers. It's a hard sell to sell treatment for PTSD to the police, even though I think significant number of police officers have sub-threshold PTSD from the chronic, horrific stress that they face every day. But a way to get in is to develop things to build resilience and to teach de-escalation communication tactics. So these are scenes from an application being used with New York City Police, soon to come out to LA, and also an application we developed with the LAPD for a home visit, where these characters are very, very annoying, and to try to teach skills working with the RAND Corporation and the LAPD. We're running a trial that'll be starting up in the summer to test this out with the police population at the LAPD Academy. But beyond police, most people don't realize that the suicide rate in docs is one of the highest. And if you look at the data for that, starting with nurses, the suicide rate for nurses is way more than the general population. From this study from, I think, 2014 data, a massive data set they had availability to, was physicians. Again, same, almost 1.5 to 2 times the suicide rate. Then you add in COVID to the mix, and you're starting to see this in an early study out of China with healthcare professionals, high levels of depression, anxiety, insomnia, and distress. Patients in China that had just been released from the hospital after having COVID filled out the PTSD checklist, the self-report checklist, and 96% met PTSD criteria. Now, that doesn't mean they have PTSD, because these symptoms are the natural response to a stressor, and you would expect anyone that's been through a stressful event to score high. We don't diagnose PTSD until at least a month or 3 months down the road, when the symptoms don't resolve. And I'll present some data later on that. Also, military suicide rate took a bump of 20% across all branches in 2020, with 30% in the Army specifically. Opioid usage was found to be significantly increased in samples taken from COVID testing randomly, 872,000 samples, showing significant increases in fentanyl and heroin during the pandemic. And a variety of other studies have been coming out showing the same findings. So we are facing a mental health tsunami ahead, and we need to be prepared for it. So we see this being a great target area, among other civilian trauma areas, with civilian sexual trauma, of course, that we intend to start focusing on. And the most recent study from COVID from Italy showed that people at least 30 days post hospitalization showed a 30% PTSD rate, which is equivalent to Katrina survivors, a little higher than World Trade Center people exposed. So, again, the data is showing this is a problem of great urgency. Our approach is, I'm just going to show one thing. I'll show a couple of videos, but it's more of a cross-platform approach, not just relying on VR alone, but using web-based applications with virtual humans, mobile apps, and so forth. And here's what one of that looks like.
I was created to talk to people in a safe and secure environment. I'm not a therapist, but I'm here to learn about people and would love to learn about you. I'll ask a few questions to get us started. And please feel free to tell me anything. Your answers are totally confidential. Are you okay with this?
Yes.
So that's an application for really helping healthcare providers have a safe place to assess or self-assess their own professional burnout and develop a self-care plan. But the combination of things like that, mobile wellness apps with virtual humans to enable them, direct VR exposure therapy, of course, and other things that can be delivered on standalone headsets to promote mindfulness, meditation, relaxation. And, basically, there's going to be plenty of clinical targets to address, post-COVID. So if you're interested in more detail, we just wrote a chapter on this. Send me an email. I'll pop you a pre-publication version of it. And I'd like to thank some of our corporate sponsors that have donated equipment and some programming skills, and also a foundation called Soldier Strong that now donates free equipment to any VA willing to run this application, the PTSD application. We started a month before COVID shut everything down and got 14 sites out. Now we've got another 10 now that we're ramping back up, and they're providing all the hardware for free. So if you're at a VA and you want to use this stuff, send me an email and we'll hook you up. All right, next area, distraction. So, this is in the area of pain management, acute pain management. And this is an area where there's significant research to show the value of using VR. And again, we always start with theory. And we know from various theories of pain perception, gate theory and so forth, that pain does require some level of attention, that if you divert attention away from the pain, you get the reduction of a perception of pain. Games may be useful for this. VR games may be even more useful, as Hunter Hoffman showed in 1999, where he compared people getting daily wound care for significant burns, playing an already distracting computer game versus playing a game in a very primitive Stone Age VR headset. And basically what he found was the perception of pain dropped precipitously in VR compared to playing a video game already distracting. That's the graph on the left. The graph on the right shows that it wasn't just a short-lived novelty effect of one time, that over 7 sessions for people getting physical therapy following skin grafts, very painful procedure, that the effect continued through 7 sessions as far as he studied it. Now, these findings have been replicated time and time again over the years. And, we really, this is one, like with the exposure approach, I think we're on pretty solid ground. Is we never have enough research, but we're on solid ground to begin applying this. And, really, since those studies, folks have done a variety of reviews and meta-analysis, all coming to the same conclusion that, VR is an effective approach for treating these kinds of painful procedures. And when you experimentally induce pain in people by putting hot thermistors on their feet when they're in an fMRI system, you see on the left, this again is Hunter Hoffman's work, your brain on VR and off VR. 5 of the core areas of the brain for perception of pain showing reduced activation during VR. The good news is there's a ton of VR content that you can use, and you can deliver it in a standalone headset. There are applications that are built specifically for pain management, as you see here, but there's a lot of content there. So this is the barriers to adoption in hospitals, particularly with standalone headsets that a nurse can pull out of her back pocket or his back pocket and give it to a patient when going through a procedure. It's a very encouraging and exciting area.
So what are these patients doing in the
What
virtual
about chronic
world?
pain?
For Pierre, he's actually moving his pain-free arm. But when he looks through the goggles, he sees the injured arm doing the work. In this case, trying to pop balloons that are floating all around him. After just 5 sessions, he says his pain disappeared.
The cost to me was really minimum, just a little bit of time and no side effects.
Dr. Sean Mackey, one of the nation's top pain experts, says the treatment works by tricking the brain.
And that's where the excitement for VR comes in, is the opportunity to rewire our brains into a more normal state so that we're not experiencing as much pain.
Is this the future of pain management?
I think it's one of the critical futures of pain management.
So the key there is that, unlike acute pain, chronic pain requires you to learn certain skills to manage it. You can't wear a VR headset 24/7, but you can learn things in a VR headset or do activities that change your perception of pain outside of VR. If you're interested in more, Hunter Hoffman wrote a chapter for a book I edited with Stefan Bouchard last year, published in 2019. Send me an email, I can send you that. One other area I want to touch on is just comfort management, because this isn't direct pain, but it's making hospital procedures a little more bearable. And you see this in a lot of areas in hospitals. Cedars-Sinai here in LA is doing significant work in this area. But one area going back in history is with Sue Schneider's work with chemotherapy, making VR a way to distract people or engage people while they're getting infusions like this.
This is virtual reality. Today, 27-year-old breast cancer patient Cindy Worthing will solve a mystery on the Titanic during her treatment.
No passengers. That means you.
Or
so very basic, primitive stuff back in 2000, 2004, in that time frame. But the results were very encouraging, with people liking it, preferring it, all the good things you would want, in addition to a time perception shift. People thought they were in the infusion for much less time than they actually were, as these patients will describe.
They asked me at the end of after the treatment, how long they thought I was on doing the virtual reality. And I said, about 20 minutes, and really it had been an hour.
But this
couldn't believe it when it was finished, because I didn't get to complete the game even.
So, and more recent findings from 2020 showing similar and better results in this area as well, even comparing it with music therapy that's commonly used, showing even better results with VR. There's a lot of areas we can go into. This guy is getting, major surgery. I'm sure he's on other anesthetics, but trying to make the experience a little less traumatic if he's awake during this type of surgery. Motivate and measure. That's the next area. Do the time. Since I'm about 10 minutes away, I'm going to have to skip some of the motivational stuff for game-based rehab. But just to touch on it briefly, traditional physical therapy, playing with toys. Yeah, you got to do this, but getting people to engage may be challenging. If you can do this, perhaps we may get more people to do more therapy and benefit from it in ways that they might not ordinarily
feel like
benefit from.
I'm on the cutting edge, and that is very exciting.
It's one of our first stroke patients that worked with us in around 2001. I'm going to just jump out of this for a second and move along to another area that I think is more relevant for this population here. Come on. Oh. My PowerPoint is going through auto recovery mode here, so it'll take about 10 seconds before I can jump ahead here. But what I'm going to cover is neuropsychology applications, particularly with that virtual classroom. Then we'll finish up with some virtual human apps and then conclude the talk. Just bear with me here.
We do have a few questions coming in as well, so just let us know when we could jump in with those.
Okay, here we go. Come on, come back. Here we go. Okay. And, in these areas of physical and cognitive therapy, there are companies that are building things out that are standalone headsets with sophisticated sensors. So we have a bright future ahead with corporate applications that go beyond some of the things you can build in the lab. Laboratories are good for basic science, but productization is a different animal. And, besides the physical therapy, there are game activities that promote exercise and relaxation. So anyway, testing and training cognitive function, I think, is an important area. And this fits in the area of cognitive assessment and rehab. Some of the early stuff, again, from the early to mid 90s for training functional skills. This app on the upper left was one of the first applications, showed that people with developmental disabilities with significant cognitive impairments could learn in a VR environment how to navigate and find things in a supermarket, and that learning translated to the real world. One of the first instances of documented transfer of training from VR to a real world app. Very primitive, as you see here. But again, the technology has evolved. So here's a kitchen app where training skills, functional skills in a kitchen, something I think OT folks might find of interest, as well as neuropsychologists, training in a functional context for different types of everyday skills. So I showed this before. I'm not going to make you watch this again. But that is the virtual classroom, and this is an early study showing differences between kids with ADHD and neurotypical kids, showing significant differences in performance in the classroom on key metrics of missed targets, omission errors, commissions, impulsive responding, reaction time, and reaction time variability. Also, we can track hand and head movement in these environments. So we're getting a metric of the hyperactivity component. So when we talk about measurement in VR, that's one of the cool things. What you see here is a randomly selected child with ADHD's head movement over a 10-minute trial. That's a red line that you see that represents that head movement. And if you look closely, you'll see a green line in there, which is a neurotypical child, and there's hardly any head movement in there, but we can go beyond even measuring and representing, visualizing the data like this to something like this, where we take that exact data you saw in that chart and plant it on these little avatar heads. So you're seeing 22 seconds into a 10-minute trial, kids are looking forward at the blackboard. Or a typical kid may look away from time to time at distractions, but he gets right back on task. A minute into the test, the ADHD kid, similarly, you're focused and so on. But as time progresses, 5 minutes in, the ADHD kid becomes more distractible. And he does try to get back on task, but he's more susceptible to the distractions being delivered in the environment. And now we're going to jump to the 7-minute mark, where in the lab we call this the exorcist clip. And basically, this is the actual head movement of this child in the simulation. He's going to see the paper airplane flying by and start tracking that. And then he's going to look up at the ceiling. And you really see how distractible these kids are. So we can measure and represent data in important ways. As well, we can quantify that movement. In the last study I showed, basically we can quantify when a child's looking out the window and missing a target, as opposed to looking straight on at the whiteboard and missing a target. Those are two fundamentally different attention errors, distractibility versus loss of focus, something that's often left out in traditional neuropsychological evaluation to determine whether a child has ADHD. Number of publications have been done with that application from 2003, research studies looking at different populations, on-off medication, training effects. This is what it looks like now. And as I mentioned with productization, this is a company I'm consulting with, Cognitive Leap, with their new version. And this has a normative data set of 700 kids, neurotypical kids for comparison purposes with our ADHD groups. And this is actually from a study being done. It was done in Taiwan, but now it's being tested at multiple sites in the United States. All right, finally, what about virtual humans? Well, we used virtual humans, not us, but another group in 1999 created this panic disorder agoraphobia app. And as you can see, these characters you'd never mistake for the real world. But in an exposure therapy context, what was found is that they were as effective as using real human actors to do this kind of in vivo exposure, something very impractical and hard to do. More recently, Stefan Bouchard's group in Canada did a similar app, but with a little bit better fidelity characters for social phobia exposure therapy, and documented showing that it was more effective than even in vivo exposure because you could do more trials in VR and you could systematically manipulate the stimuli. Fear of public speaking, similarly, over the years, people have addressed this most common phobia for people. And now you can get almost free applications on these standalone headsets to practice your skills. And we kind of give this a pass as psychologists because, well, public speaking, it's a skill, even though it could be a clinical condition. Self-help, okay, are we on a slippery slope with this? But, this will be a contentious issue in the future of psychology, how much we should push out to people without a therapist's involvement. Another area where virtual humans are relevant are in the area of autism. And people have been doing this work as well over the years, from 2002 for training social skills. Sue Cobb's work in the UK. Our work with the Dan Marino Foundation, as I showed earlier on, 6 different characters, 6 different backdrops, 3 different provocative levels. Here's one of our users talking about their experience in this training context.
It's a good program, and it teaches you how to do an interview, and it teaches you how to be in an interview situation with another person.
And did you see your performance improve? Did you get better?
I get better every single time I do it. I get better.
So that's data down there on the first clinical test of it that was published in 2017, I believe, showing significant improvements from the first face-to-face live interview to multiple VITA, vocational interview training agent interviews, and then finally transfer training effects with a vocational counselor rated post-interview. We also have done this with augmented reality, just as an experimental thing. So this user is wearing see-through glasses, the Magic Leap headset, and seeing the character sitting at the desk in that empty chair. Anyway, a lot of work to be done in these areas, a lot of new technology. I'm going to have to skip this because I don't have time. It's another autism application. It's very impressive, but sorry, I'll have to come back and do another talk and catch up on what I didn't cover for you guys. But one area I do want to cover, since you saw the virtual patient app from earlier on, certainly training clinicians in medicine, but in psychology and social work is an important area. And this is an area we focused on since 2007, as you saw earlier.
Good afternoon.
This is what it looks like now, similar to the vocational interview context. Multiple characters can be put in different contexts, and built an authoring system so expert clinicians can build out, training cases for people to practice their skills. We've got 40 different characters. Each character can be inflated to 3 different weight classes, which may be relevant in a clinical diagnosis of perhaps a guy on the left. If he's coming in with heart problems, maybe it's an anxiety disorder or eating disorder. The guy on the right, maybe, maybe it's a body mass issue. Anyway, the goal here is to make clinical training go beyond the see one, do one, teach one model to, more objective ways of doing it. We recently published a paper training motivational interviewing.
Hey, how's it going?
And this one gave users in training the option to select
I'm good. Look,
choices.
this is my wife's idea.
And they verbalize the choices, but they could also point and click, and there was a virtual coach that would pop up. And what we found was that this was published in JAMA, Journal of American Medical Association Open Network, and basically in a randomized controlled trial at the Puget Sound VA led by Greg Rieger, basically found way better performance on real world motivational interviewing skills after doing the VR approach as opposed to the standard online approach. And that effect endured over a 3-month period when we brought folks back into the setting and did another assessment with a live actor patient as the model. Anyway.
I'm going to jump in because this has been,
okay.
Or maybe you're
Real
on your,
quick.
there's the summary.
Yep.
This has been amazing. Thank you.
So, expose, distract, motivate, measure, and engage. In the context of what I presented, I think clinical VR is theoretically informed, scientifically supported. We have low-cost, high-fidelity technology, a passionate development community. And with that, let me just jump ahead. There's a market out there. The projections show an $80 billion market from Goldman Sachs, primarily with entertainment and video games, but if you look at healthcare, that comes in second, and other analyses are predicting a high market there. There are companies popping up. VBI, Virtually Better, has been around since '97, but these are companies that have emerged in the last 3 or 4 years. More companies producing this kind of content in the last couple of years than in the previous 20. So a lot of stuff happening, scientific community evolving, conferences popping up all over the place so that we have a scientific community being built to share findings and so on. And to conclude, if you want to, shameless promotion, this is the full book. If you can't afford it online, send me an email. I might be able to sneak you a PDF of it if you're a student and can't afford to buy it. But, VR has really evolved over the years. These are my niece and nephew. When I flew back to Connecticut for Christmas a few years back, I brought my first standalone headset and Samsung Gear VR, and they were fighting all day over who gets to play with it. But a couple nights before, I flew in and my flight was delayed. I didn't get in till like 3 a.m, but my mom was waiting up for me. So when 3 a.m, she's meeting me at the door. First thing I said, Mom, I need a beer and I want you to try this VR headset. So this is that.
It's so real. My God, it looks like my backyard, my yard with the snow. Oh, Lord in heaven. How they ever can create this. You know what? I'm hanging onto the sink because I'm afraid I'm going to fall down the cliff. Yeah, honest to God. You feel like, if you step off, you're going to fall right in there. Holy mackerel.
And one last pitch for my mom.
If you're watching this, please fund my son's research so that he can take care of me in my old age.
So with that, if you want a copy of this talk with all the video embedded, I'll post it later today. You can download it, send me an email, I'll send you the link. And thank you very much for your time and attention. Sorry, I went a few minutes over.
Thank you so much.
For
folks that are still on, do you have a couple of minutes just to take a few questions?
Oh, certainly. I can stay as long as you need. So
all right.
No problem there. You want me to jump, stop sharing my screen?
Sure, yeah.
There we go.
And so we've had some questions around if VR could be used for the treatment and prevention of addiction, like drugs, alcohol, gambling. And another question around being able to make this strategy available for low resource communities or those with limited English proficiency. And then we have a few others.
All right, real quick, the answer to both of those questions is yes. With addiction, interest of time, I couldn't cover that area, but Patrick Bordnick's work at University of New Orleans stands out. I mean, at Tulane University, the other university in New Orleans. He's dean of social work, but he's done a lot of work with what they call Q exposure. And basically you put people in provocative environments. It fits in with an exposure model. And you activate urge states while they're in rehab and they can't use, and trying to break the potency of the external stimulus cues by repeated exposure, urge state, but no consummatory behavioral approach. But I also believe there's a strong cognitive element there, teaching people relapse prevention skills, but in a context that may transfer. And it's, that area isn't as evolved as the phobia or PTSD work, but there's some good initial findings and a bit more work to go with. Translating this to underserved populations and different language issues, that's the beauty of doing things in a digital format. You can take what you got and you can start to modify it around the needs of different user groups if you have the funding. And there's a lot of good happening in that area with funding and so forth.
Yeah. Two related questions, which is funny to see them. This is terrific. So you mentioned virtual reality tools will be used by trained clinicians, and thinking about implementation, how would you recommend training clinicians to use these? As another participant phrased it, as wonderful interventions.
Okay, well, for a lot of these applications, it does leverage an already existing clinical process, like with PTSD prolonged exposure. We don't just willy-nilly hand out the software. You have to have documentation at your site that you've been trained in prolonged exposure. And then we provide a 2-day training that Soldier Strong, the foundation I mentioned, pays for. And so far, we've run 2 of them right before COVID in January. We ran one in Asheville, North Carolina, and one in Dallas, Texas, with 10 clinicians, and a deep dive into how to use the equipment, how to implement it ethically and professionally, and so on. And this is where it's got to go in the future, like that virtual patient stuff. We have a prototype of virtual patient wearing a VR headset, so maybe we can start to train people in implementation. But in honesty, the field is evolving in a way where graduate schools need to have classes in VR. VR is no longer some sci-fi dream. It's a functional technology. Again, the ultimate Skinner box, just meat and potatoes simulation technology. When I would do these talks in the early 2000s at APA and other psych conferences, people would be shaking their head. And I'd say, look, if you have doubts here, think about when you're flying home from this conference, would you want your pilot trained and certified in how to deal with wind shear or fog landing in a simulator? Or would you rather they learn that from reading it out of a book or death by PowerPoint talk or on the job training? And you could see a few light bulbs going off that this isn't Star Trek holodeck. I mean, it could be in the future. It's a functional technology for delivering things. If we do it properly from a theoretically informed basis and do the science, I think we can have a significant benefit. And clinical psychology and other clinical professions really need to get on board with this. And they are gradually.
A recent question was about you showed a couple examples of older adults using this. So are there ways to sort of any data on this for older adults, and how can we motivate older adults to participate besides your mom?
Well, yeah, right. She was a willing participant.
Yeah.
For sure. There are companies, 2 that comes top of my head, Rendeavor and Mind VR, MYND, that actually make content on standalone headsets that they're distributing to senior care facilities for respite. you know, and the idea, the preliminary data is showing that people are less agitated when they can have a 20-minute break from the doldrums of the center they're in. And, you know, the care provider has a touchpad that, you know, can go, Mr. Jones, you want to do fly fishing in Idaho in a spherical video context, or go to the top of the Himalayas, places you've never been to or seen before. And it's promising.
Yeah.
They actually use Google Earth and have sent people back to home, to the street where they grew up as kids, like as a reminiscence therapy thing. So there is hope for it. And there's also more clinical hope. We've done some studies with elderly folks looking at visual spatial abilities. The early days, as you know, maybe a supplemental approach to Alzheimer's diagnostics, but it's not limited to just young folks. It's surprising. Like my mom's reaction is not that different than a lot of folks for, you know, when they put on that headset and all of a sudden turn their head and the magic happens, you know, pretty engaging.
Amazing. Should we close out?
All right. Well, I see where people are dropping off, so I think we'll leave it there. But Skip, always a pleasure. And thanks for giving the talk, and I do hope that we're able to catch up at some point when this pandemic.
I'll make a trip to Chicago so we can discuss it over beers in person.
Perfect.
All righty.
Okay.
Thank
you.
Thanks.
Bye-bye, everyone. Thank you.
Thank you.